Bismillahirrahmanirrahim. In this video, we are going to study certain diseases of the nasal septum. The nasal septum is the structure that is basically dividing the nostrils into two portions, or the nose into two nostrils. First of all, we'll discuss about septal hematoma. But before, we need to study the anatomy of the nasal septum. The nasal septum has a cartilaginous part, which is this part, and it has a bony part, which is this part. Okay, above this cartilaginous part, we have a layer of mucoperichondrium, and above this bony part, we have the mucosa is basically called as the mucoperiosteum. So what is septal hematoma? It is basically a collection of blood under the perichondrium or the periosteum of the nasal septum. So mostly it is there in the under the septal cartilage. That the septal cartilage, this is the nasal septum, and this is suppose the mucoperichondrium of the nasal septum. The cartilage is generally an avascular structure, and the cartilage is gaining its blood supply from the mucoperichondrium. But in case of any trauma to the facial structures or the nose, what will happen is sharp buckling forces will pull the closely adherent mucoperichondrium from the underlying cartilage. So it will be something like this. The mucoperichondrium will be pulled because of the sharp buckling force or the facial trauma. This causes the rupture of submucosal vessels, and that ultimately results in the collection of blood between the cartilage, which is an avascular structure, a cartilaginous part of the nasal septum, and the mucoperichondrium. Okay, hematoma thus formed results in pressure-related ischemic changes. Why is the hematoma formed? Because of the rupture of the submucosal vessels of the mucoperichondrium. Okay, so now the cartilaginous part of the nasal septum cannot derive its blood supply from the overlying mucosa. This can lead to the necrosis of the septal cartilage. Okay. Now, septal hematoma can present at any age, but mostly it is seen in children, and there may be a history of some nasal trauma during sports or other activities. So the child or whatever the age of the patient is, they will present with a complaint of nasal obstruction and pain over the nasal bridge, accompanied by frontal headache. Why will there'll be complaint of the nasal obstruction? Because the hematoma is occluding the nasal fossae. It is making the nasal fossae narrower. Now, it may not develop exactly after the blunt trauma. It may develop few days after the blunt trauma. So, a high index of suspicion should be kept, especially if a patient presents with nasal deformity or nasal pain following trauma. Okay? And also, if post-traumatic nasal obstruction does not resolve with a local vasoconstrictive agent or a decongestant or a blood clot removal, the possibility of a nasal hematoma should be strongly considered. A nasal hematoma also creates a trouble in the ventilation of the nasal airflow, so that can also lead to symptoms of nasal obstruction, especially symptoms of nasal obstruction or trouble with the ventilation of airflow. Or whistling sounds during inspiration are seen in septal perforation that we'll study in a while. This is the picture of septal hematoma. This is basically, let me change my color. This is basically the nasal septum. These are the middle and the inferior turbinates, and this layer is the layer of the mucoperichondrium. In between the nasal septum, and probably because this is the initial part of the nose, so the initial part of the nose is that of the cartilage. So this must be the mucoperichondrium. In the later part of the nose, it can be mucoperiosteum, and here the blood has collected. Now this cartilaginous part of the septum cannot have its blood supply from the mucoperichondrium, and later that can lead to necrosis or fibrosis of the nasal septum. There can be thickening of the nasal septum, and if the septal hematoma is not drained within 72 hours, a secondary infection can supervene. And the secondary infection is basically the proliferation of bacteria in the blood, okay, which is basically called as a septal abscess. Now, how to examine a patient who comes with the complaints of a septal hematoma? First of all, we'll use this Thydicum speculum, which is used to see the floor of the nasal cavity, the lateral wall of the nasal cavity, and the nasal septum. If the child or if the patient is a child, he may not allow you to press over the bridge of the nose because of the pain is associated. So you may have to use an anesthesia along. Okay. So what is the treatment of a nasal septum hematoma? The mnemonic is AINS, which is basically the aspiration using a wide bowl sterile needle. Okay? And if it is a larger hematoma, then you'll have to give an incision or a drainage which is parallel to the nasal floor. Apart from the incision and drainage, we also excise a small piece of the mucosa which can be the mucoperiosteum or the perichondrium. We also excise a small piece of the mucosa. मेरा कहने का मतलब ये है that we can collect this blood and we can incise and drain this blood, and we can also collect a piece of this mucosa from the edge of the incision so that we can drain it better. Okay, generally the incision is given just in the very lower part which is the nasal floor, but we can also give a little nick to the mucosa so that there is better drainage. And after that, you'll have to give a nasal packing for at least 24 hours so that you can prevent reaccumulation. But how long you have to give the nasal packing depends on how much blood was collected there and how much chance of reaccumulation is there. And systemic antibiotics to prevent septal abscess. Okay, what can be the other causes of septal abscess apart from a secondary infection of the septal hematoma? It can also be caused by a furuncle of the nose, and it can of the nose or the upper lip, and it may also follow acute infection like typhoid or measles. So here the child may present to the child or the patient may present with some additional complaints like that of fever and the enlargement of the submandibular lymph nodes, and the history of a trauma if it is a complication of a septal abscess may be given a few days back, like at least 3 to 4 days back. Okay, so again, when we will palpate that swelling, the swelling will be the swelling is going to be soft and fluctuant. It won't be hard. It won't be hard, because hard swelling can indicate the thickening of the nasal septum itself. So it will be soft and it will be able to move, which is it is able to fluctuate, and the septal mucosa will be congested. What is the treatment of the septal abscess? The mnemonic is ISRA. First of all, you'll have to give an incision again in the dependent part of the abscess, and we will also excise a portion of the septal mucosa for easy drainage. Then we'll have to, because there'll be some necrosis of the septal cartilage by now, so you'll have to do some suction of the necrosed pieces of the cartilage. Okay, and you may have to reopen and again drain the abscess a few days later. So incision may be required to be reopened daily for 2 to 3 days to drain any pus or to remove any necrosed pieces of cartilage. Systemic antibiotics, definitely they have to be started as soon as you make the diagnosis of a septal hematoma, and they should be continued for 10 days, and culture sensitivity of the pus will guide the choice of the antibiotic. The complications of septal abscess are the necrosis of the septal cartilage. When the septal cartilage will get necrosed, that can lead to a depression of the cartilaginous dorsum in the supratip area, and then you may have to do a rhinoplasty later to correct the external nasal deformity. And it can lead to septal perforation, and it can lead to serious complications because this septal abscess is in the dangerous triangle of the face. This is basically the dangerous triangle of the face. So this septal abscess can spread to our cavernous sinus, or it can cause meningitis, and these complications are pretty serious, though they are rare. Let's talk about the septal perforation. If you encounter a patient of septal perforation, the first thing that you have to do is to find the cause. And if you are unable to find the cause, immediately do the biopsy of the granulations or the edge of the perforation. The possible causes that you may have to rule out during history taking is the history of a trauma. Trauma can be during surgery. Similarly, I forgot to mention that septal hematoma can also be caused by septal surgery, or it may be caused by any bleeding disorder. A bleeding disorder sometimes lead to spontaneous formation of a septal hematoma. So you have to rule out and ask these questions in history: that was there any trauma? Do you have any bleeding disorder? Has this occurred to you before? Or had you any septal surgery in the past? Traumatic perforation can occur during a submucosal resection surgery. It can occur during cauterization of the septum as an epistaxis treatment. It can also be caused by habitual nose picking or deliberate perforation to put ornaments. So this is basically related to trauma, that it may be a trauma itself, it may be a surgery or a cauterization as a treatment of epistaxis, it may be a deliberate thing to put ornaments, or it may be caused by habitual nose picking. Next, you'll go for the pathological causes. It may be because of a septal abscess. It may be caused by nasal myiasis, which is basically maggots in the nose, a rhinolith, or any foreign body. And the other thing is the chronic granulomatous disease. You'll be able to see the causative agent in the other systems of the body also. What are the chronic granulomatous diseases? There is lupus, there is leprosy, and TB, which cause trouble to the cartilaginous part of the nasal septum. And there is another one, which is basically syphilis, which causes trouble to the bony part of the nasal septum, and that can lead to a septal perforation in the bony part. Another one is Wegener's granuloma, or natural killer cell or T cell lymphoma. They can even cause a total septal destruction. So there's a midline destructive lesion in that case. Okay, so you have to rule out these pathologies through multiple blood tests and through detailed history taking. Then you have to talk about the demographics. In the demographics, you may ask that if that person has any occupational exposure of chromium plating, dichromate, soda ash, or arsenic. You may have to ask in the personal history if the person is a cocaine addict, and you may ask in the treatment history whether he has been using steroid sprays for more than 6 months in the past without any break in between. Idiopathic is that there may be no history of a trauma or previous disease, and the patient may even be unaware of the existence of the perforation. So the perforation can be small, it can be large. And the small anterior perforation can cause whistling sounds during inspiration or expiration. And the large perforations, they develop crusts which obstruct the nose, and they cause severe epistaxis when those crusts are removed. They also lead to nasal blockage and improper nasal ventilation, as I mentioned before. So what is the treatment? After doing a detailed biopsy and finding out the cause, you will have to move towards treatment. So if there's a small perforation, you can close it. using the plastic flaps. But if there's a larger perforation, then the first goal is to keep the nose crust free using alkaline nasal douching or application of a bland ointment. And sometimes you can use a silastic button that can be worn to get relief from the symptoms.